This video contains the important points from one of our live sessions. In this video, I'm trying to show you how I run my live courses. If you're preparing for PACE or AMC Clinical and want to join one of these courses, you can head on to learnmedicine.com.au. All our courses are AMA CPD home approved. So if you complete the course, you can also claim CPD hours. Let's watch the video now. Just remember, the actual video is 90 minutes long, and this one only contains the highlights from that video. What if this is a case of irritable bowel syndrome then? Which is a functional gastrointestinal disorder. A very common presentation, by the way. You'll be surprised when you will start practicing that almost every one patient out of 3 will have this presentation here. So this is our case here, a 52-year-old female with bloating and constipation. Patient profile, age is 52-year-old, gender female, chief complaint bloating and constipation. Investigation status, already has done so many tests and everything came out normal. Patient is frustrated. Patient wants you to find out what is happening there, or the task will be either take history and talk about the investigation, or history and management, or history and counsel the patient. IBS has come in different ways. So opening will be same. History taking, if it comes as a history taking case, it will not be any different than how we have taken the history before. Just make sure that you know what is the Rome 4 criteria for IBS diagnosis. Okay, so if you don't remember, maybe revise Rome 4 criteria for IBS. These things are similar, so I'm not going through them. Past medical history, family history, all questions you're asking here is almost exactly same as what you ask in IBD. Your main positive findings will come here. Social and contextual history are the IBS triggers. So here, when you're asking the SADMA questions, your focus will be more on the stressors, like are you under any particular stress at the moment, at work or at school, depending on the age of the patient, at work, at school, at home, wherever it is, because stress is the major trigger for IBS. Dietary history, why it is important, as I told you that their symptoms tend to be triggered by certain kind of food, which we call FODMAP, or the fermentable oligo, di and mono saccharides and polyols. That is the FODMAP diet. So those food, because they have a lot of fiber, they are not digested. Because they are not digested, they have broken down by the gut bacteria, which produces a lot of gas. The gas stretches the colon stretching causes the pain and bloating. And so that's why they have these triggers. Now comes the question, which will help you to understand the pathophysiology. But that should happen to everyone, right? The gut bacteria should break down the high fiber diet, high fiber food, and make gas and cause bloating and constipation. If it happens, if it's an objective thing to happen with those kind of food, then why some people complain of pain and complain of diarrhea and complain of discomfort and others do not? And that's where the new pathophysiology, a new hypothesis about the pathophysiology of IBS comes into play, where we are not simply saying gut-brain axis because it's in your head and head is affecting your gut and that's why you have the pain. We don't explain it in that way anymore. What we say is some people have hypersensitive gut. So they feel the pain more than others. And that's why when they have certain kind of triggers, they respond more sensitively than the others. So you are not making this up. It's just that your gut is carrying this sensation to the brain and brain is interpreting it more sensitively than others. And that's why you have these symptoms. So we are not saying gut-brain axis. The gut-brain axis is just an incomplete explanation of what is happening, and it kind of simplifies the problem too much, almost being dismissive at the patient's concern that it's in the gut, that's why it's in the brain, that's why it's affecting the gut. Or gut affects the brain, brain affects the gut, which is true, but it does not explain why then it does not happen to everyone, because some people are just more sensitive. And I did not go into the details of this new hypothesis. If you are interested, you can read the paper yourself, which basically says that the nerve endings in these people are more sensitive and there is a richer innervation of the gut in people who have IBS. So positive history, in this case, you'll find that unlike the other cases, you'll not find any alarming symptoms. You'll not find any extraintestinal manifestation. You'll not find any blood or mucus in the stool. You'll not find any change in weight unless they are practicing restrictive diet. The symptom timeline, usually they will come with either the constipation dominant type or the diarrhea dominant type, and depending on that, they'll share their symptoms. If they are the constipation dominant type, then their symptoms, their triggers usually will cause constipation. If they are diarrhea dominant type, their triggers will usually cause diarrhea, and they can mix type as well. Now, pain characteristic here this is usually where they have the pain in the left iliac fossa. It improves after the bowel movement. As I told you that if it's inflammatory, then the bowel movement actually causes more pain, because if you are manipulating the inflamed bowel, you'll get the pain. But in these people, once you open the bowel, the pain becomes less. And bowel pattern is, in this patient, it was the constipation predominant, but he also had diarrhea. Or it could be the other way around as well. In the exam, it will not be unusual for AMC to change this slightly. So your patient might be the diarrhea predominant with the constipation sometimes happening in between. And alarming symptoms, as I said, 0. Investigations all normal. Psychological factor you will find positive is patient is anxious type, has a stressor at home in school or home and work, and they will tell you that they have recently been promoted, or they will tell you that this tends to happen whenever I have to go for my company presentation. So the day before the presentation, my symptoms become really worse and I have to take medications. I have to use loperamide, which is the gastro-stop medication here. Or they will give you some triggers like this tends to happen in this particular situation, some kind of stresses. So what is Rome 4 criteria and how it can help us in making the diagnosis? So Rome 4 criteria says that the pain has to be recurrent at least more than 1 day a week in the last 3 months. That is one thing. So patient must have abdominal pain first, and the pain should be associated with defecation. That means the pain becomes better when the patient passes the stool. There is change in the stool frequency and form. That means it can be diarrhea, it can be constipation, doesn't matter. Just the frequency and the form has to change. Is either the frequency become less or becomes too many, or the form becomes hard or becomes loose. And symptom onset has to be more or equal to 6 months ago. So these are the criteria to make the diagnosis of IBS. And this patient meets the criteria. Why? Because the pain has been in the left iliac fossa for 3 months. The pain improves after bowel movement. There is constipation alternating with diarrhea and long-standing constipation history, which is definitely more than 6 months. So he meets all the criteria, or she meets all the criteria. That's why. And she does not have other possible diagnosis, because IBS is a diagnosis of exclusion, and we have already asked the presenting complaint of the other condition. So we can now comfortably make the diagnosis of IBS because we have asked all the relevant questions now. So as I said, in exam, there has been a case where you have to counsel the patient about what is IBS, how it presents, and how we manage the case. And I already have a video about this in the counseling course. You can watch that video about IBS and how to explain it to the patient. Basically, the new hypothesis says that the reason some people have this and others do not is because of the visceral hypersensitivity, which simply means exaggerated pain response to normal gut stimuli. Visceral afferent neurons in gut wall become hypersensitive, which activates the immunity, and then it starts the low-grade inflammation. Again, we will be avoiding the mast cell infiltration and those kind of things. Alteration in the bacterial composition and function, gut microbiota changes, just makes it more prominent. Usually FODMAP diet is the trigger, and it alters the pain perception and the communication between the gut and the brain because of the hypersensitivity. The simplified version was the one that I told you. It's simply that your gut is more sensitive to different triggers than others, and your brain is interpreting your gut's pain perception more than in other people. That's why you are getting the abdominal pain, bloating, and diarrhea. So that is the simplified version of the explanation, but you can create your own explanation if you find your version easier to explain to the patient. As I said, counseling has been a case. I still things are the things perhaps you already know, like keep a food diary, do exercise, manage your stress, and low FODMAP diet. So FODMAP diet generally means this kind of diet they avoid. And basically you can see that these are the food which usually have high fibers. And onions and garlics can also make their symptoms worse. And what we say is we have to do this with the help of a dietitian. We ask the patient to get in touch with the dietitian. They don't start doing it themselves, because there are 3 steps of FODMAP diet in implementation with the dietitian. First is the dietitian asks them to avoid all FODMAP diet, and then they gradually introduce one type of diet at one time, and then until they figure out which diets cause the symptoms. And then in the third step, then only those diets are avoided, because not all of this food in the FODMAP diet will cause these problems. This concept was propounded by the researchers in the Monash University in Melbourne, and it's based on that concept. And this has been successfully implemented in case of people presenting with irritable bowel syndrome. So make sure you are familiar with what to avoid and what patients can continue. If it comes as a counseling case, you can do that. That's why we need dietitian to do this. Psychologist, because it's stress related condition, so we need the psychologist to manage the condition. What about the medications? Yes, we can use medications to manage the symptoms depending on what is the predominant symptoms. If the patient has pain, then we can give them antispasmodics. We don't need to know about the pain medications name for AMC, but let's say that if you want to mention the name antispasmodics, we have two options that have been listed in therapeutic guidelines. One is the hyoscine bromide, which is also called Buscopan, or the hyoscine bromide, which is an antispasmodic that helps with the pain. The other one is peppermint oil capsules. So both of these can be used as antispasmodics, and patients take this with their food. We don't need to know about the doses. Buscopan or peppermint oil can be used for the abdominal pain relief. Medications like paracetamol, Nurofen are not recommended. And of course, codeine containing medications should be avoided because they can make the constipation worse. Tricyclic antidepressants can be used for the pain modulation, as we know that they have very good effect on the neuropathic pain. And if the patient has diarrhea, you can use loperamide. So depending on what is the presentation of the patient, you can use this. Most of the times what you tell the patient is you use as needed or on-demand therapy. They usually don't use it all the time. They just use it when they need to use it. So if we summarize the main points that we'll have to remember while counseling the patient: fiber, natural antispasmodics, and there are some emerging therapies like the gut microbiota transplantation and probiotics, which do not have proven efficacy yet. If you want to mention, you can. There are certain specific, strains of the lactobacillus species we can use, like Lactobacillus reuteri and those one. Again, that is beyond the scope of AMC exam. We don't need to know that much, but you can say that some people have tried probiotics as well as some experimental therapies as well, but at the moment we do not have conclusive evidence about their efficacy. Holistic approach is the most important approach required to manage IBS. So when you are doing the IBS counseling, if you watch my video, I have used the 5C approach that I have discussed in counseling cases. Make sure that you use that format while counseling the patient. 5C stands for condition, cause, and you can talk about commonality as well. If you know about how common it is, most of the times you wouldn't remember the percentage, so you'd just be using some generic words anyway. So condition, cause, and commonality, and then you can talk about the clinical features, like how it presents, and complications. What happens if you don't treat it? What if it keeps progressing, and what happens with the treatment? So with and without treatment, what happens? You talk about that. And care, which is basically the management options, like what you do for the patient, how you care about the condition. Or you can also talk about the course as well, care and course. So if you make a format like this, if you start explaining everything like this, then I think any kind of case will be easy for you. IBS, as I said, has come in 3 different ways. It has come as a case where you have to take the history and talk about the diagnosis and differential. It has come as a case where you just ask relevant history and you start counseling the patient, where you already know what the diagnosis is. You just try to find out the triggers for the patient and you explain to the patient how to manage the condition. It has also come as a case where you have to ask the history, look at the investigation findings and physical examination findings. Both are normal. And then after that, you have to tell what the diagnosis is. So it has come in many different ways. But I hope now most of the diarrhea cases you'll be able to handle without much problem.